Assalamu alaikum, fourth year MBBS. This is Dr. Iqra Saboor. Topic of today's lecture is diphtheria. I hope and I pray that you all are tackling well with the current situation of lockdown due to COVID-19. Let's move forward with the lecture. Okay, what are the learning objectives of today's lecture? Firstly, we will learn about its introduction, what is diphtheria, how it is caused, its global and regional distribution, its epidemiological determinants, its mode of transmission, what are different modes of transmission, why it is important to know the modes of transmission, its clinical features, immunization, and lastly, its control. Okay, diphtheria basically it is an acute infectious disease which is also known as khannak in Urdu. It is caused by strain of Corynebacterium diphtheria. Three major clinical types they have been described: anterior, nasal, facial, and laryngeal. However, the skin, conjunctiva, vulva, and other parts of the body they may be affected. The bacilli multiply locally, usually in the throat, and elaborate a powerful exotoxin which is responsible for number one, the formation of grayish or whitish membrane, which is known as the false membrane, commonly over the tonsils, pharynx, and larynx with well-defined edges, and the membrane cannot be wiped away. Number two is marked congestion, edema, or local tissue destruction. Number three is enlargement of the regional lymph nodes. And number four, the signs and symptoms of toxemia. What are the signs and symptoms of toxemia? That is severe headache, blurred vision, proteinuria, upper abdominal pain, nausea, vomiting, decreased urine output. So these are the signs and symptoms of toxemia. Okay, now we will move towards the global and regional uh, distribution. In 1920, approximately 150,000 cases occur, and within those cases, 13,000 deaths reported annually. After diphtheria immunization, the number of the cases they fell to about 19,000 in 1945. In 2012, the WHO estimated that about 2,500 deaths occur annually worldwide. Regarding Pakistan statistics, in 2020, among the 92 suspected cases, 24 cases, including 5 deaths, were confirmed. Okay, what are the epidemiological determinants? Firstly, its agents. The causative agent, as I have told before, it's a Corynebacterium diphtheria. It's a gram-positive, non-motile organism, and it has no invasive power but produces a very powerful exotoxin. Four types of diphtheria bacilli they are differentiated, named as gravis, mitis, Belfanti, and intermediates. Gravis infection tend to be more severe. The toxin, basically, which is generated by bacteria, it can affect the heart, leading to myocarditis, and to the nerves, leading to paralysis. Uh, Diphtheria bacilli, remember, they are sensitive to penicillin and are readily killed by heat and chemical agents. They may survive for short periods in dust and fomites. So, what are the source of infections? Uh, the source of infection, it may be a case or a carrier. In case of a specific case, a cases ranges from a subclinical to a frank clinical cases. Mild or silent infections may exhibit no more than a mere running nose or a sore throat. These cases play a more important role than frank cases in spreading the infection. Regarding the carriers, they are a common source of infection. Their ratio is estimated to be 95 carriers for 5 clinical cases. So carriers may be temporary. They can be temporary or chronic, nasal or throat carriers. The nasal carriers, they are particularly dangerous source of infection because of frequent shedding. Frequent shedding of organism into the environment. The temporary carrier state, it may last for about a month, but the chronic carrier state, it may persist for a year. The incidence of carriers in a community may vary from 0.1 to 5%. Okay, immunization does not prevent the carrier state, right? That is why it's very uh, important factor in spreading the infection. Regarding the infective material, nasopharyngeal secretions, discharges from the skin lesions, as I have told you about the fomites, contaminated fomites, and possibly infective dust. They are the infective material. What is the period of infectivity? It's 14 to 28 days from the onset of the disease, but carriers may remain infective for much longer period. Okay, if a case or a carrier may be considered non-communicable when at least two cultures properly obtained from the nose and throat 24 hours apart, they are negative for diphtheria bacilli. Okay, what are the other determinants? Host factors, includes age. Diphtheria particularly affects children aged 1 to 5 years. In countries where the widespread immunization is practiced, a shift in age incidence has been observed from a preschool to school age. The next determinant comes the sex. Both sexes, they are affected. Regarding the immunity, infant born of immune mothers, they are relatively immune during the first few weeks or the months of the life. Before the artificial immunization, large proportion of the population in developing countries were acquiring active immunity through inapparent infection, which resulted in widespread production of antitoxin in the population. Thus, most members of the population except children were immune. By the age 6 to 8 years, approximately 75% of the children in developing countries were where the skin infection with the Cranibacterium diphtheria, they are common. They have protected serum antitoxin levels uh, already present in their blood, right? Okay, since diphtheria is principally the result of action of the toxin formed by the organism, resistance to the disease depends largely on the availability of specific neutralizing antitoxin in the bloodstream and tissue. It is generally true that diphtheria occurs only in persons who possesses no antitoxin. Um, Assessment of immunity to diphtheria toxin for individual patients, they can best be made by review of documented diphtheria toxoid immunization and primary or booster immunization if needed. Regarding the environmental factors, cases of diphtheria, they occur in all seasons, although winter months favors its spread. Okay, to have a better control of any disease, we should know all its different types of mode of transmissions. The mode of transmission of diphtheria is mainly by droplet infection. It can also be transmitted directly to susceptible persons from infected cutaneous lesions. Transmission by object, for example, cups, thermometers, toys, pencils, contaminated by the nasopharyngeal secretion of the patient is possible, but for only short period. Regarding its portal of entry, respiratory route is common. The non-respiratory route contains skin where the cuts, wounds, and ulcers they are not properly attended to. They may get infected with the diphtheria bacilli, and so is the umbilicus in the newborn. Occasionally, the site of implantation may be the eye, genitalia, or the middle ear. The non-respiratory routes of infection are less common in developed countries where the spread by the droplet infection is more common. What regarding the incubation period, uh, its incubation period is 2 to 6 days, occasionally longer. Okay, this slide just shows you the distribution on the types of diphtheria. it exists in two forms: respiratory form and non-respiratory. Respiratory form contains pharyngotonsillar, laryngeotracheal, and nasal form, and non-respiratory contains cutaneous, and it involves the mucosal surfaces of conjunctiva and genitals. Okay, regarding the pharyngotonsillar diphtheria, patients with this, they usually have sore throat, difficulty in swallowing, and low-grade fever at presentation. So you must know the clinical symptoms so that you can diagnose it at once. Examination of throat, they may show a mild erythema, localized exudate, or a pseudomembrane. The membrane, it may be localized or a patch of the posterior pharynx or tonsil. It may cover the entire tonsil, palate, and the posterior portion of the pharynx. In the early stage, the pseudomembrane, it may be whitish and may wipe off easily, but the membrane may extend to become thick, blue-white to gray-black and adherent. Attempts to remove this membrane, it will result in heavy bleeding. A minimal area of mucosal erythema surrounds the membrane. Patients with severe disease may have marked edema of the submandibular area and the interior portion of the neck, and along with lymphadenopathy. That's why it's called a bull-necked appearance. So this is a very catchy point: bull-necked appearance. Okay, the next form is laryngeotracheal diphtheria. It is most often preceded by the pharyngotonsillar disease, usually is associated with fever, hoarseness, and croupy cough. That's its catchy point. And if the infection extends into the bronchial tree, it is the most severe form of disease. Initially, it may be clinically indistinguishable from viral croup or epiglottitis. Prostration and dyspnea soon follow because of the obstruction caused by the membrane. This obstruction may even cause suffocation if not promptly relieved by intubation or tracheostomy. Okay, class. The last form of the respiratory diphtheria is the nasal diphtheria. It is the mildest form of respiratory diphtheria. Usually, it is localized to the tip of the turbinates of one side of the nose. Occasionally, a membrane may extend into the pharynx, and also I have uh, displayed a picture of cutaneous diphtheria, which is a form of non-respiratory diphtheria. uh, that is the it involves the mucosal surface of conjunctiva and genitals. Cutaneous diphtheria is common in tropical areas. Okay, it often appears as a secondary infection of the previous skin abrasion or infection. Presenting lesion, often an ulcer, may be surrounded by erythema, as you can see in the picture, and covered with a membrane. Patients generally seek treatment because of the chronicity of the skin lesion. Now, most important, we move towards the control of diphtheria infection. Have a better control, we should control three forms, or we should have a control at three levels. First is cases and carriers. Um, Secondly, we should control the contacts, and then we should apply the control measures in the community. Okay, regarding the control of the cases and carriers, four steps they are taken. First is the early detection, isolation, treatment, and disinfection of nasal and throat secretion. Firstly, for the early detection, an active search for the cases and carriers, they should start immediately among the family and the school context. The carriers, they can be detected only by culture method. Swabs, they should be taken both from the nose and the throat and examined by culture methods for diphtheria bacilli. Tests should be made for the virulence of the organism. Regarding the isolation, all the cases, suspected cases and carriers, they should be promptly isolated for at least 14 days or until proved free of infection. I have told you criteria how to mark a patient free of infection. That was at least two consecutive nose and throat swabs taken 24 hours apart should be negative before terminating isolation. Regarding the treatment cases, they should, uh, when diphtheria is suspected in diphtheria antitoxin, they should be given without delay, intramuscularly or intravenously in doses ranging from 20,000 to 100,000 units or more, depending upon the severity of the case. After a preliminary test dose. For mild early pharyngeal laryngeal disease, the dose is 20,000 to 40,000 units. For moderate disease, 40,000 to 60,000 units. And for severe disease, 80,000 to 100,000 units are required. In addition to the antitoxin, every case should be treated with the penicillin or erythromycin for 5 to 6 days to clear the throat of Corynebacterium diphtheria and thereby disease toxin production. Regarding the treatment of the carriers should be treated with 10 days course of oral erythromycin, which is the most effective drug for the treatment of the carriers. Along with the treatment, the immunity status they should be upgraded. Okay, regarding the control of contacts, they should be throat swabbed and their immunity status should be determined. Different situations they pose different options. If the primary immunization or the booster dose it was received within the previous 2 years, no further action is required. If the primary when the primary course booster dose of diphtheria was received more than 2 years before, only a booster dose of toxoid is required. And when non-immunized close contact non-immunized close contact is present, then it should receive the prophylactic penicillin or erythromycin. It should be given 1,000 to 2,000 units of diphtheria antitoxin, immunized against the diphtheria. Contacts they should be placed under the medical surveillance and examined daily for evidence of diphtheria for at least a week after the exposure. Regarding the control over the community, the only effective control is by active immunization with diphtheria toxoid of all the infants as early in the life as possible as scheduled, um with subsequent booster dose every 10 years thereafter. The aim should be to immunize before the infant loses his maternal derived immunity so that there will be continuous protection from the birth without any gap in immunity to natural disease. The vaccine being a toxide is not derived against the organism, therefore immunization does not prevent the carrier state. I have mentioned this before. Consequently, the non-immune individuals they are not protected by a high level of population immunity. This implies that immunization rate must be maintained at high level. That's the answer of mentioning why at the end point regarding the control in the community. Okay, regarding the diphtheria immunization, they are categorized in three forms. That is the combined and mixed vaccines, single vaccines, and anti-sera. What comes under the combined and mixed vaccine? This is DPT, DTPW, DTPA, DT, and the adult diphtheria tetanus type. Lastly is the pentavalent. You should know, as the name suggests, it covers 5 diseases. You should know what are those 5 diseases. It covers against diphtheria, tetanus, pertussis, hepatitis B, and Haemophilus influenza B. Regarding classification of the single vaccines, FT formal toxoid, APT alum precipitated toxoid, PTAP is purified toxide aluminium phosphate, PTAH purified toxide aluminum hydroxide. PAF is the toxide antitoxin flocculus. And what comes under the anti-sera is the diphtheria antitoxin. Okay, regarding the different types of vaccines, different forms of vaccines, DPT vaccine, pentavalent, and anti-sera, you should know. the contraindication or the side effects of side effects of these vaccines, and most importantly, their dose and their route of administration. Okay, um for immunizing the infants, the preparation of choice is DPT. Firstly, because the infants can be immunized simultaneously against three diseases: diphtheria, pertussis, and tetanus, which is a great gain administratively. Secondly, the pertussis component in DPT vaccine enhances the potency of the diphtheria toxide. Just remember that. There are two types of DPT vaccines: plain and adsorb. For adsorption, a mineral carrier, aluminum phosphate or aluminum hydroxide is used. Uh, for for the storage of the vaccine, temperature should be 2 to 8 degrees Celsius. It should not be frozen, right? Its optimum age of application is that young infants, they respond well to the immunization with potent vaccines and toxoids. Uh, and regarding the number of the doses, 3 doses of the DPT, each of which is usually 0.5 ml, it should be considered optimal for primary immunization. Right? There should be a 4 week of interval between the doses. So the right time of the 3 doses will be 6 weeks, 10 weeks, and 14 weeks, as it is included in the EPI. That is expanded program of immunization. What is the mode of transmission? The mode of transmission is intramuscular in anterolateral aspect of thigh, and the reactions from this vaccine is fever and mild local reactions following the DPT immunization. The most severe complication following the DPT immunization are neurological. Encephalitis. Just remember this. This is very important. What are those severe complications? These are encephalitis, encephalopathy, prolonged convulsions, infantile spasm, and they are thought to be due to primarily to the pertussis component of the vaccine. The estimate risk is 1 in 170,000 doses is administered. Okay, what are the contraindications? The contraindications um are that minor illnesses, such as cough, cold, mild fever, they are not considered uh, contraindications to vaccine. Only those children who are severely ill and need hospitalization, they are not vaccinated, right? DPT should not be repeated if a severe reaction occurred after a previous dose. Since the severity of the pertussis infection decreases with the age, the pertussis component in DPT vaccine is not usually recommended after the age of 6 years. Just remember, if a child above 5 years of age come to in hospital clinic for DPT vaccination first time, the pertussis component will be omitted from it. I will repeat it. Since the severity of the pertussis infection decreases with age, the pertussis component is in DPT vaccine is not usually recommended after the age of 6 years. Therefore, children over the age of 5 years who have not received the DPT need only 2 doses of DP vaccine 4 weeks apart, with the booster dose 6 months to 1 year, right? For immunizing the children over the 12 years of age and adults, the preparation of choice is D, small d in capital T, that is the adult type, right? Regarding the pentavalent vaccine, pentavalent, as I have told you before, it provides protection to a child from 5 life-threatening diseases: diphtheria, pertussis, tetanus, Haemophilus influenza B, and uh, hepatitis B. Giving pentavalent vaccine reduces the number of pricks to a child. So when used, it replaces the hepatitis B and DPT primary vaccination schedule like 10, and 14 weeks in the immunization program, except the birth dose of hepatitis B and booster doses of DPT, they are continued, right? The storage temperature of pentavalent vaccine is same as that of the DPT vaccine, that is 2 to 8 degrees Celsius. It is administered intramuscularly in a dose of zero point 0.5 ml at anterolateral aspect of the mid thigh. Right? Regarding the antisera, antisera, it includes diphtheria antitoxin, which prepared in horse serum, is still the mainstay of passive prophylaxis. Okay, antisera gives a passive prophylaxis and also for the treatment of diphtheria. Okay, this slide is just to show you what are different vaccines which are included in our EPI program at the national level. Just remember that uh, this EPI program, it's protect child against 10 diseases by the age of 15 months, right? At birth, you give BCG, OPV, hepatitis B. As we are concerned about the vaccination, so diphtheria vaccination is started at second visit, that is 6 weeks, and 6 weeks, four, and then after with the regular interval of 4 weeks apart, 6, 10, and 14 weeks. Right? You should know the dose and the route of administration of DPT vaccine and its contraindications.
Now, I know you don't like needles, but getting your diphtheria booster shot is very important. You can catch diphtheria from a sneeze or a cough from an infected person. After a few days, you could get fever, chills, swollen lymph nodes. Here, I'll show you what happens. You see that grey-coloured gunk? That's made up of diphtheria bacteria. They can give you a sore throat, cough, difficulty breathing. A whole range of other very serious complications could also develop. There, done. That wasn't so bad, was it? Now, you're over 50, so you should be getting a booster too. Some things never change.
Thank you, class. If you have any question, you can ask in the comment section.